Welcome back, everyone. Today, we will start our lecture with physiological consequences of cardiac tumors. Cardiac tumors produce symptoms through several important mechanisms. First, they may cause systemic or pulmonary embolization. Fragments of the tumor or associated thrombi can detach and travel through the circulation. Right-sided tumors typically cause pulmonary emboli, whereas left-sided tumors may cause systemic emboli, resulting in a stroke or ischemia of other organs. Second, tumors may obstruct blood flow through the heart, producing symptoms of heart failure. Depending on their location, they can interfere with ventricular filling or ventricular outflow. Third, cardiac tumors can interfere with the normal function of the heart valves, producing valvular regurgitation. Fourth, direct invasion of the myocardium may impair left ventricular function and lead to arrhythmias, heart block, or precardial effusion. And finally, many patients experience constitutional symptoms including fever, weight loss, fatigue, and malaise. Subtypes of cardiac tumors by location. The clinical presentation depends greatly on the tumor's anatomical location. Right atrial tumors. Right atrial tumors frequently obstruct blood flow through the tricuspid valve, producing symptoms similar to tricuspid stenosis and right-sided heart failure. Fragments from these tumors may embolize into the pulmonary circulation, causing pulmonary embolism. If the tumor involves the atrioventricular node, it can produce heart block. And one of the most common right atrial tumors are the myxomas. Right ventricular tumors. Tumors in the right ventricle may interfere with the ventricular filling or right ventricular outflow, leading to right-sided heart failure. They may also obstruct blood flow or produce tricuspid regurgitation, mimicking mitral valve disease and resulting in secondary pulmonary hypertension. Left atrial tumors. Left atrial tumors commonly release tumor fragments or thrombi into the systemic circulation, producing embolic complications such as a stroke. Again, myxomas are among the most common tumors in this location. Left ventricular tumors. Intramural left ventricular tumors commonly cause arrhythmias or conduction abnormalities. Intracavitary tumors may obstruct left ventricular outflow or produce systemic embolization. Progressive myocardial involvement can ultimately result in left ventricular failure. Valvular tumors. The most common valvular tumor is the papillary fibroblastoma, which occurs with similar frequency on atrioventricular and semilunar valves. Although these tumors are often asymptomatic, they may first present with distal embolization or coronary ostial obstruction. When feasible, tumor excision with valve repair is preferred over valve replacement. Precardial tumors. Precardial tumors include lipomas and metastatic tumors. They may compress the heart extremely because of their mass effect and frequently produce precardial effusion. Subtypes of cardiac tumors by histopathology. Benign cardiac tumors. Approximately 75% of all cardiac tumors are benign. The most common benign tumor is the myxoma, which most frequently arises in the left atrium. In adults over the age of 16, the three most common primary benign tumors are myxomas, about 50%, lipomatous tumors, about 21%, papillary fibroelastomas, about 16%. In children younger than 16 years, the most common tumors differ and include rhabdomyomas, approximately 55%, teratomas, 16%, fibromas, 10%, and myxomas, 10%. Because of the high risk of embolization and other cardiovascular complications, myxomas should be surgically removed whenever possible. Primary malignant cardiac tumors. The majority of primary malignant cardiac tumors are sarcomas, accounting for approximately 75% of cases. Sarcomas are aggressive tumors that grow rapidly, infiltrate the myocardium, obstruct cardiac blood flow, and metastasize early. Unlike many cancers, prognosis depends more on the anatomical location than on the histological subtype. Right-sided sarcomas tend to be more invasive and metastasize earlier than left-sided tumors. Whenever feasible, complete surgical resection is recommended. However, recurrence is common. Current evidence suggests that combining surgery with chemotherapy provides better survival than either treatment alone. Metastatic involvement of the heart. Secondary or metastatic cardiac tumors are much more common than primary cardiac tumors. Cancer may spread to the heart through hematogenous dissemination, direct invasion from adjacent structures, extension through the vena cava into the right atrium. Metastases occur most frequently in the outer layer of the heart, particularly the pericardium, reflecting spread through the coronary circulation or direct extension from nearby thoracic malignancies. Whenever a patient with known cancer develops new cardiovascular symptoms, clinicians should suspect cardiac or pericardial metastasis. Although many cardiac metastases remain asymptomatic, the most common clinical manifestation is pericardial effusion, which may progress to cardiac tamponade. To summarize this page, cardiac tumors cause disease through obstruction, embolization, valve dysfunction, myocardial invasion, arrhythmias, and constitutional symptoms. Myxomas are the most common benign cardiac tumors and most commonly arise in the left atrium. Papillary fibroelastomas are the most common valvular tumors and can cause embolic events. Sarcomas are the most common primary malignant cardiac tumors and are highly aggressive. Metastatic cardiac involvement is more common than primary cardiac malignancy, with pericardial effusion being the most frequent presentation. Early recognition and surgical management, when appropriate, are critical for improving patients' outcome. Valvular heart disease. Now we begin with the valvular heart disease. The Toronto Notes recommend referring to the 2020 American College of Cardiology and American Heart Association guidelines. and the 2017 ACC and AHA focused update for the most current recommendations on diagnosis and management. These guidelines help determine when patients require medical therapy, intervention, or surgery based on disease severity and symptoms. Infective endocarditis. Let's discuss infective endocarditis. An important exam point is that antibiotic prophylaxis is no longer recommended for everyone. According to the 2007 American Heart Association guidelines, prophylaxis is reserved only for patients at highest risk of adverse outcomes. Patients who require IE prophylaxis include patients with prosthetic heart valves or prosthetic valve material, patients with a previous history of infective endocarditis, patients with cyanotic congenital heart disease, cardiac transplant recipients who later develop valvular disease. Equally important is knowing which procedures require prophylaxis. These include dental procedures involving manipulation of gingival tissue, selected respiratory tract procedures, and procedures involving infected skin, skin structure, or musculoskeletal tissue. A common examination question asks about gastrointestinal or genitourinary procedures. Remember, routine GI and GU procedures do not require infective endocarditis prophylaxis. Rheumatic fever. Let's move to rheumatic fever. For the detailed disease process, Toronto Notes refers you to the pediatrics chapter. Today, we'll focus on the cardiac prognosis and long-term complications. Acute cardiac complications include myocarditis, which may progress to dilated cardiomyopathy or congestive heart failure. Conduction abnormalities, including sinus tachycardia and atrial fibrillation. Valvulitis, commonly causing acute mitral regurgitation. And acute pericarditis, although this is generally non-constrictive. Coronary complications. Over time, chronic inflammations produces fibrosis, thickening of the valve leaflets, valve adhesion, and calcification. These structural changes eventually produce valve stenosis, valve regurgitation, increased risk of infective endocarditis, and increased risk of thromboembolisms. A very important clinical point is that symptoms often appear 10 to 20 years after the initial episodes of rheumatic carditis, making rheumatic heart disease a delayed complication. The mitral valve is the valve most commonly affected, making mitral stenosis the classic long-term manifestation. Valve repair and valve replacement. The indication for surgery depends primarily on severity of the valve disease, symptoms, failure of medical therapy, and evidence that intervention will improve symptoms or prognosis. Valve repair. Whenever technically possible, valve repair is preferred because it preserves the patient's native valve. Repair techniques include valvuloplasty, commissurotomy, annuloplasty, placement of a tissue patch. Valve replacement. If repair is not feasible, valve replacement is performed. Replacement most commonly involves the aortic valve and mitral valve. One important decision is selecting between a mechanical valve and a bioprosthetic valve, especially in patients between 50 and 70 years of age, where the optimal choice depends on individual patients' factors and remains an area of ongoing discussion. Choice of valve prosthesis. Now let's review Table 17, mechanical valve versus bioprosthetic valves and versus pulmonary autograft, the Ross procedure. Mechanical valve. Mechanical valves are characterized by excellent long-term durability, high risk of thromboembolism, lifelong anticoagulation with warfarin, and higher bleeding risk due to anticoagulation. They are generally preferred in patients younger than 50 years for aortic valve replacement, patients younger than 65 years for mitral valve replacement. These valves are ideal for younger patients who can safely maintain lifelong anticoagulation. Bioprosthetic valve. Bioprosthetic valves offer lower risk of thromboembolism, usually no need for lifelong anticoagulation, especially in the aortic position, and lower bleeding risk. However, they have limited durability because they gradually degenerate over time. They are generally preferred in patients older than 65 years, where valve longevity is less of a concern, and avoiding long-term anticoagulation is beneficial. 3. Pulmonary autograft or Ross procedure. The Ross procedure involves replacing a deceased aortic valve with the patient's own pulmonary valve. Its advantages include excellent hemodynamic performance, flow characteristics closest to a normal native aortic valve, very low thromboembolic risk, and no lifelong anticoagulation, better quality of life including safer pregnancy and unrestricted physical activity. This procedure is most appropriate for children and young adults younger than 50 years. Because it's technically demanding, it should only be performed in high-volume centers with extensive experience. Clinical peril. The study highlighted on the right side of the page compares mitral valve repair with mitral valve replacement in degenerative mitral regurgitation. Its key finding is that mitral valve repair is associated with lower operative mortality, better 20-year survival, and fewer valve-related complications than mitral valve replacement. This evidence supports the current principle in cardiac surgery. Whenever feasible, repair the native mitral valve rather than replace it. To summarize this page, IE prophylaxis is reserved for high-risk patients undergoing a specific high-risk procedures. Mitral valve disease is the most common chronic manifestation of rheumatic fever. Surgical intervention is indicated when severe valve disease causes symptoms or when medical therapy is insufficient. Valve repair is preferred whenever anatomically possible. Mechanical valves provide excellent durability but require lifelong anticoagulation. Bioprosthetic valves avoid long-term anticoagulation but have limited durability. Table 17 is a high-yield comparison of mechanical valves, bioprosthetic valves, and the Ross procedure, and is frequently tested in examinations. Management and follow-up. Let's begin with the long-term management of patients who have undergone prosthetic valve replacement. Follow-up depends on several factors, including the type of prosthetic valve implanted, any residual heart disease, and the patient's overall clinical condition. The cornerstone of follow-up is transthoracic echocardiography, or TTE. A TTE should be performed after valve implantation to assess valve hemodynamics, ventricular function, and baseline prosthetic valve performance. If the patient later develops symptoms or clinical signs suggesting prosthetic valve dysfunction, such as dyspnea, heart failure, or a new murmur, a repeat TTE should be performed immediately. Additional investigation may also be necessary. For patients with surgical implanted bioprosthetic valves, routine surveillance include TTE at 5 years, again at 10 years, and annually thereafter if the patient remains asymptomatic. For transcatheter bioprosthetic valves, annual TTE following implantation is considered reasonable. Patients should also receive excellent dental care, appropriate and infective endocarditis prophylaxis when indicated. Antithrombic therapy. Antithrombotic treatment should balance the risk of thrombosis against bleeding. For mechanical valves, lifelong anticoagulation with a vitamin K antagonist such as warfarin is required. INR monitoring is also essential. For patients with bioprosthetic TAVI, prosthetic surgical AVR, or mitral valve replacement, short-term oral anticoagulation or antiplatelet therapy may be indicated depending on the clinical circumstances. Prosthetic valve-related complications. Unfortunately, prosthetic valves may develop complications over time. Prosthetic valve dysfunction. Currently, there are no medical therapies that prevent degeneration of either mechanical or bioprosthetic valves. Common causes include structural tissue degeneration, panospermation, infective endocarditis, and valve thrombosis. Patients usually present with prosthetic valve stenosis, regurgitation, or symptoms of heart failure. Management depends on the underlying pathology, severity of the disease, patient's specific factors. Thromboembolic events. When a patient with a prosthetic valve develops a thromboembolic event, clinicians should evaluate whether anticoagulation has been adequate, time is spent within the therapeutic INR range, new onset atrial fibrillation, infective endocarditis, other embolic sources, and underlying hypercoagulable disorders. If a patient with a mechanical valve experiences embolism despite a therapeutic INR, management may include increasing the INR target and adding low-dose aspirin. For patients with bioprosthetic valve who develop embolic events while receiving only antiplatelet therapy, switching to vitamin K antagonist anticoagulations should be considered. Valve thrombosis. Valve thrombosis differs between mechanical and bioprosthetic valves. Mechanical valve thrombosis. Mechanical valve thrombosis usually develops as a subacute or acute event. It is commonly associated with inadequate anticoagulation. Repeated thrombosis may also occur with pannus ingrowth. Patients often present with sudden worsening dyspnea, acute pulmonary edema, prosthetic valve stenosis, new murmurs, and or soft absent mechanical closing clicks. Urgent investigations include TTE, transesophageal echocardiography or TEE, fluoroscopy, multi-detector CT imaging. If the thrombosed valve is left-sided and causing obstruction, urgent treatment is required using either fibrinolytic therapy or emergency surgery. Bioprosthetic valve thrombosis. Bioprosthetic valve thrombosis occurs most frequently during the first 3 months after implantation. Fortunately, bioprosthetic valves are much less thrombogenic than mechanical valves. Diagnosis is made using TTE, TEE, or four-dimensional CT imaging. When confirmed or strongly suspected, treatment with a vitamin K antagonist is reasonable if the patient is hemodynamically stable without contraindications to anticoagulations. This may continue. Graft dysfunction after the Ross operation. Now let's discuss complications following the Ross procedure. Common causes include autograft dilatation, right ventricular outflow tract conduit stenosis, pulmonary regurgitation. Patients may present with aortic regurgitation, pulmonary stenosis, pulmonary regurgitation, aortic root aneurysm. Evaluations include echocardiography, MRI if aortic root aneurysm is suspected. Treatment is best performed at the experienced centers. For autograft dilatations, reoperation is often successful because the autograft is usually repairable. For RVOT graft dysfunction, transcatheter pulmonary valve replacement is generally preferred. Surgical pulmonary valve replacement remains an option. Ross operation. Let's briefly review the Ross operation. The Ross operation involves removing the patient's native pulmonary valve, transplanting it into the aortic position to replace a deceased aortic valve, reconstructing the right ventricular outflow tract using cadaverous pulmonary homograft. The advantages include excellent hemodynamics, leaving autograft capable of growth and adaptation. Very low rates of late reintervention when performed in experienced centers. Although technically more complex than a standard isolated aortic valve replacements, long-term morbidity and mortality are comparable when performed by expert surgeons. Evidence summary. The page concludes with two important evidence summaries: mechanical versus biological prosthesis. Researchers comparing mechanical and biological valve shows mechanical valves generally offer greater long-term durability. However, they require lifelong anticoagulation and carry a higher bleeding risk. Bioprosthetic valves avoid lifelong anticoagulation but are more prone to structural degeneration and further reintervention. Valve choice should therefore be individualized based on patient's age, bleeding risk, life expectancy, comorbidities, and patient's preferences. Ross procedures compared with the bioprosthetic aortic valve replacement. Recent studies suggest that Ross procedure improves long-term survival, reduces valve-related complications, lowers rates of thromboembolic events, decreases the need for future intervention in appropriately selected younger patients. These excellent outcomes are achieved primarily in experienced high-volume centers. To conclude this page, follow prosthetic valve patients with a scheduled TTE surveillance. Mechanical valves require lifelong warfarin anticoagulation with INR monitoring. Evaluate prosthetic valve dysfunction promptly using multi-modality imaging. Mechanical valve thrombosis is a medical emergency requiring urgent thrombolysis or surgery. Bioprosthetic valve thrombosis often responds to anticoagulation The ROS procedure is an excellent option for carefully selected young patients offering outstanding long-term survival and physiological valve performance. Prosthetic valve selection should always balance durability, bleed-on risk, reintervention risk, and patient's preferences. Let's move on to the next page. General principles for evaluating valvular heart disease. The evaluation begins with a comprehensive initial assessment. The first step is to obtain a detailed history and physical examination. During the history, assess the patient's symptoms, including dyspnea, chest pain, syncope, palpitations, fatigue, and exercise tolerance. Determine the severity of the symptoms, identify the affected valve, evaluate associated comorbidities, and assess whether heart failure is present and how severe it is. The cornerstone of diagnosis is the transthoracic echocardiogram, or TTE, which is considered the standard initial investigation. Echocardiography provides information about chamber size, ventricular systolic function, valve morphology, the severity of valvular stenosis or regurgitation, and its effect on both the pulmonary and systemic circulation. An electrocardiogram ECG should also be performed to evaluate cardiac rhythm, detect left ventricular hypertrophy, and assess evidence of ventricular dysfunction. Further testing when indicated. Additional investigations are selected based on the patient's clinical presentation. A chest X-ray is particularly useful in symptomatic patients. It helps assess heart size, pulmonary vascular congestion, intrinsic lung disease, and detect aortic or precordial calcification. A transesophageal echocardiogram TEE provides superior visualization of the mitral valve and prosthetic heart valves when transthoracic imaging is inadequate. Cardiac magnetic resonance imaging CMR accurately evaluates left ventricular volume and function, aortic pathology, and the severity of valvular disease. PET CT scanning is mainly used to identify infection or inflammation, particularly when prostatic valve endocarditis is suspected. Stress testing evaluates exercise capacity and may uncover symptoms in patients who appear asymptomatic. Cardiac catheterization is useful for measuring intracardiac pressure, pulmonary artery pressure, and hemodynamic responses during exercise or pharmacological stress. It also helps determine the severity of valvular lesions when non-invasive studies are inclusive. Future risk stratification. Beyond diagnosis, clinicians assess the patient's future risk. Cardiac biomarkers such as BNP or NT-proBNP serve as a surrogate markers of myocardial stress, myocardial damage, and elevated filling pressure. Myocardial strain analysis using TTE detects subtle ventricular dysfunction before the ejection fraction declines. Cardiac MRI can identify myocardial fibrosis, which is associated with the worst long-term outcomes. Stress testing can also contribute to prognostic assessment by evaluating functional capacity. Before intervention, procedural risk should be estimated using validated scoring systems, including the Society of Thoracic Surgeons STC score and TAVI risk score. Finally, assessment of frailty is increasingly important because frailty strongly influences operative risks and postoperative recovery, particularly in elderly patients. Pre-procedural testing. Before valve surgery or transcatheter intervention, several investigations are routinely performed. A dental examination is recommended to eliminate potential sources of infections, and reduce the risk of infective endocarditis. Patients usually undergo invasive coronary angiography or CT coronary angiography to identify significant coronary artery disease that may require simultaneous treatment. For patients undergoing transcatheter valve procedures such as TAVR, a CT scan of the peripheral arteries and heart is essential to evaluate vascular access and accurately size the prostatic valve. Stages of valvular heart disease. Valvular heart disease progresses through 4 clinical stages. Stage A, at risk. These patients have risk factors for developing valvular disease but no significant structural valve abnormality and are generally asymptomatic. Stage B, progressive disease. Patients have mild to moderate valvular disease but remain asymptomatic. Regular clinical follow-up and echocardiographic surveillance are recommended. Stage C, severe asymptomatic disease. At this stage, severe valvular disease is present, but symptoms have not yet developed. Stage C is divided into 2 subgroups. Stage C1, severe disease with compensated left or right ventricular function. The ventricles continue to maintain adequate cardiac output despite the valve lesion. Stage 2, severe disease with decompensated left or right ventricular function, indicating ventricular dysfunction despite the absence of symptoms. These patients often require earlier interventions to prevent irreversible myocardial damage. Stage D, severe symptoms disease. Patients have severe valvular disease accompanied by symptoms such as dyspnea, angina, syncope, or heart failure. This stage generally represents a clear indication for valve intervention, either through surgical valve replacement or repair or transcatheter procedures, depending on the patient's surgical risk. To summarize, the evaluation of valvular heart disease begins with a careful clinical assessment and transthoracic echocardiography, followed by targeted imaging and functional testing when necessary. Risk stratification incorporates biomarkers, myocardial strain, cardiac MRI, procedural risk scores, and frailty assessment. Before intervention, clinicians perform dental evaluation, coronary imaging, and CT planning for transcatheter procedures. Finally, remember the 4 stages of valvular disease. Stage A, at risk. Stage B, progressive, mild to moderate disease. Stage C, severe but asymptomatic. C1, compensated. C2, decompensated ventricular function. Stage D, severe symptomatic disease requiring intervention. Understanding this structured approach is essential for determining the appropriate timing of treatment and improving patients' outcomes. Thank you for attending this lecture. If you're new to the channel, don't forget to like and subscribe and press the bell icon.